a plaque psoriasis. It's a patient with pustular psoriasis. The association here, or the reminiscence, is with the rash associated with reactive arthritis. It looks so much like it, and indeed, some patients with reactive arthritis who may have a urethritis or an enteric infection which persists, who develop blenorrhagica on the soles of their feet, may then evolve into psoriasis and psoriatic arthritis. So there really is an overlap. There is, however, no association between the extent of the psoriasis and the presence or absence of an arthritis. About 10 to 20% of people with the rash will get an arthritis. There's a patient with just a little patch around the umbilicus, and you remember the psoriasis may have gone. It may have been and gone, the patient may not even be aware of it. There's a patient who had arthritis, unaware of a tiny patch on the elbow. It's more likely, however, that the patient will not notice a patch of psoriasis in the scalp, which is, of course, one of those places where you will search assiduously in the patient who has an arthritis you can't fully explain, or indeed musculoskeletal pain that you can't fully explain, and you find a patch of psoriasis in the scalp, not necessarily on the hairline, or on the umbilicus, or in the anal cleft, or on the extensor surfaces, you have a diagnosis. So you find psoriasis in 2% of the population. It really is very common. If you take a population of patients with seronegative polyarthritis, you'll find psoriasis in 15%. Many have the label of rheumatoid arthritis. Of course, you can't exclude the possibility that they may have rheumatoid arthritis, an incidental psoriasis, because it's so common. But what is rheumatoid arthritis? If you don't have rheumatoid factor and you don't have anti-CCP, it's a different disease. We drew attention to the differential impact of rituximab on rheumatoid disease. If you don't have rheumatoid factor, it doesn't work as well. So in seropositive arthritis, you see psoriasis in 2%, which is the same as in the population. And arthritis in psoriasis, as I've already said, 10 to 20%. Unlike rheumatoid arthritis, the sex distribution is equal. So I've made some reference to the fact that a patient who's got musculoskeletal pain and who has psoriasis, more than that, who has a past history of psoriasis or family history of psoriasis, is quite likely to have a disease associated with psoriasis. And that's reflected in this expanding definition for clinical trial purposes. But it's absolutely essential to look at the nails in all patients who have musculoskeletal pain without an obvious diagnosis. Look at the skin carefully, look at the scalp, and I've told you the sites that you need to look. Also note that inflammatory markers are only raised in half of patients with clear-cut psoriatic arthritis. It's, again, quite different from rheumatoid arthritis. And you expect not to find rheumatoid factor or anti-CCP. Routine X-rays, but this is a point I want to emphasize. If you have this skill, or if you have access to this skill, in a patient presenting to you with this, who may otherwise be given the diagnosis of fibromyalgia, or I don't know, and there's any hint that there may have been psoriasis, do ultrasonography, because that may well detect either subclinical synovitis, but more likely evidence of enthesitis around the ankles, around the wrists, around the knees, at other sites. So the addition of ultrasonography to the investigation of patients with psoriasis and pain